Dr. Dana now. Thank you.
Okay. Well, the IOA is very blessed to have Dr. Dana Goldman with us again. He's a very engaging and exciting presenter, as you will find out here. He's an attorney and an osteopathic physician. He will be presenting on medical, ethical, and legal issues facing today's physicians. Burning issues in medical jurisprudence and medical ethics. Welcome.
It's a pleasure to be here today with you all, and I see so many familiar faces. Thank you all for inviting me back to Indiana to present to you all on topics near and dear to my heart. We're going to be looking today at issues related to patient care from different perspectives, including and not limited to legal presentations. We're going to look at the concept of informed consent. We will look at exceptions to informed consent. We will then look at errors in practice. And when we think about errors in practice, we're going to look at how we address those errors. And then we're going to also look at benzodiazepines and antipsychotic medications and how we should best utilize those and apply those. I have no financial disclosures to make. And as we think about what we're doing, I'm a physician, I treat patients. What is the first thing I should do before treating a patient? When we think about that, this red silk illustrates the pain that our patients experience and suffer when they present to us. And our goal as physicians is to help alleviate that pain. That is our purpose and what we hope to achieve and accomplish. What do we do first as a physician? First thing we have to do is obtain informed consent. Whether we are initiating medication, whether we are engaging in a procedure, whatever we are doing, it is imperative that the patient understand the potential risks, side effects, benefits of our intervention, and that they are given the requisite amount of information so that they can consent in an informed manner. When we think about that, in 1914, there was a famous legal case where Justice Benjamin Cardozo announced the concept of informed consent, and that was every man and woman of adult years and sound mind has the right to decide what shall be done with his or her own body. Now, this concept then slowly evolved through the concepts of bioethics, autonomy, beneficence, non-maleficence, and justice are the four key components of bioethics. And it is autonomy, from the Greek word, bless you, autonomos, that means self-rule, from which we get confidentiality, privacy, and as important, if not more important, informed consent. Several cases evolved for us to learn what informed consent means to us as practicing physicians. First case of informed consent, Nathanson v. Klein, taught us the materiality of the, taught us, in fact, the reasonable medical practitioner, that we as physicians have to be reasonable in our provision of care to our patients. Then came the next case, Canterbury case, materiality of the information. We have to give that information that is material for our patients to understand what is going to happen so they can make a judicious, informed decision. Then came Truman v. Spence, which is what we all labor under, and that is not only do we have to explain to patients the risks and benefits of having a procedure performed, we also have to explain the risks of not having the procedure performed. So now we also have to explain to patients that there may be alternative treatment approaches as well. Well, we covered all of that. The key is this: we have to document what we do. The old aphorism in the law, if it wasn't written, it wasn't done, also applies to our medical charts. If we haven't included the information in our medical chart, then woe to us, because if something goes awry, if there is a medical misadventure, then we will have trouble showing that we did what we said we did. So it's very important to document. Are there ever any instances where it's ethical not to obtain informed consent? Well, the answer is yes. There are 4 exceptions to the informed consent requirement. However, I advise you not to use them. There is one, and that's the emergency situation on which you can rely. However, the other 3, I will tell you, can be major potholes on the highway of our medical practice. And what are those? The 4 exceptions to the need for material disclosure, as you see on the slides, are: number 1, common knowledge. That's when something goes awry, and as our defense, we say it's common knowledge that this could happen. Everyone knows this. It's in the newspaper. It's on the television. It's on the internet. However, it creates a dilemma for us. And it was out of the case, in fact, of common knowledge that Truman v. Spence, where the physician said it's common knowledge that if the individual doesn't have an annual pelvic and pap smear, that things can get very, very dangerous for the individual. That's common knowledge. And the court said in that case, well, it may be common knowledge to you, but it wasn't common knowledge to your patient, who refused the pelvic and pap smear every year, developed cervical cancer, and died. And so therefore, please don't rely on the common knowledge exception, even though it's still there. Please don't rely on that. Please still explain to the patient. In fact, you'll see the one, the competent patient who seeks not to know, at the very bottom. This is the individual who says to you, "Doc, look, I don't need to know. You're the doc. You know what I need. Just go ahead and do it for me." And then when there's a medical misadventure, then a plaintiff's attorney will take a totally different perspective. So please, even when the individual says, "Don't tell me, I don't need to know," please say to the patient at least, "I know you don't want to know that there's the potential risk of the following things. I know you don't want me to tell you about the potential side effects of this medication," and you go through all of them, and then you say, "Okay," after you've given them all of that information, if that makes sense. When patients present to my practice and they smoke 3 or 4 packs of cigarettes a day, when I go through my mental status exam and evaluation and find out how much they smoke, I say to them, "Don't worry, I know you hear this all the time. I'm not going to tell you about all the dangers of smoking, aging of the skin, bladder cancer, lung cancer, emphysema. Please know, I won't wear you out with those kinds of things. However, I want you to think about them, and I know that it would be very beneficial if we could help you cut back on your smoking. We could get you on a smoke cessation program. However, I won't wear you out with that today." And it's already in, and I've got it. And now the patients heard the information, and what they also heard was, I'm not going to wear them out with it. And so they're very friendly about it. Therapeutic privilege, professional discretion. What is that? And I have exercised that in the past, however, with a twist. And I'll tell you what the twist is. Therapeutic privilege is that you are concerned that in explaining potential risks and side effects to the patient, that he or she will be actually traumatized by hearing these potential risks and side effects. And so, oftentimes what I will do, if the individual is an elder care patient or an adult patient and they have family with them, I will ask their permission to discuss it with the family. If they are a child or an adolescent, I have the parents' ear as well, and I will explain it to the parents. I will document that I explained it to the parents. And therefore, I still have appropriately someone who has the understanding and has the wherewithal to intervene for this individual without me traumatizing the individual by explaining all of the potential risks, side effects, dangers. It's the emergency situation. Those of you who work in the emergency room, patients present oftentimes in extremis. They may be unconscious. They may not be capable of verbalizing informed consent. And therefore, in those situations, you have to act immediately, and informed consent is imputed. And so you want to document the patient was unable to discuss issues due to the patient's medical status. If family is available, then you'll want to discuss it with the family as well. The 4 potential exceptions. In those exceptions, bless you, we want, bless you again, we want to explain to family or others who have the permission with whom we may speak. Are there different kinds of mistakes in medicine? And does it make a difference what kind of mistake I make? And the answer is yes to both. There are 2 types of errors. There's an omission and there is commission. What is the difference? Omission is we fail to do something. What's an example? We fail to ask the patient, are you allergic to any medications? It's critical that we ask that because we don't want to engage in the commission of them prescribing a medication to which a patient is allergic, because that then can create a legal nightmare for us. So we have the omission and the commission. And then we have the error in fact and the error in judgment. The error in fact is wherein lies the omission and the commission. Error in fact is that we failed to do something indeed, or that we did something indeed that led to an untoward result. And we want to be cautious because we know as physicians and clinicians, it has the potential to have a negative impact on our wallets. And again, we have to be careful with that because we certainly don't want an omission or a commission to take our wallet and to set it ablaze and cause us to feel our practices burning to the ground. So when we think about the omission and commission, we think about the error in fact. Now what about an error in judgment? What is the difference between an error in judgment and an error in fact? And if you see me smoking or catching fire, please let me know immediately so I can douse myself with water. An error in judgment. We've asked all the appropriate questions. We've evaluated the patient correctly. We've ordered the labs. We've ordered the scans. We've done a full physical exam. And now we've made an accurate diagnosis. And now we've come up with a plan for treatment. We've discussed the plan for treatment with the patient. We have obtained informed consent. And yet, things go afoul. Is it possible that we will hear from a plaintiff's attorney? Of course, it's possible we'll hear from a plaintiff's attorney. However, it is much easier to defend an error in judgment than it is to defend an error in fact. An error in judgment, let's use an example. A patient presents to a practice, and let's just say the patient is presenting suffering from a major depressive episode, connoting major depressive disorder. The individual comes in and we ask about sleep, appetite, memory, concentration, energy, libido. We ask about loss of interest in daily life activity. We ask the individual if he or she is feeling sad and depressed. We go through that. All of those are positive from the patient, so we know that we have a major depressive episode. The patient tells us, not only am I sad and depressed, I'm sleeping all the time, I'm eating all the time, and I have no energy. So now we have the triad of an atypical depression. When we think about treating an atypical depression, one of the medications that is best tuned for treating an atypical depression is bupropion hydrochloride, brand name Wellbutrin. Now, we know with Wellbutrin, it has the potential to lower the seizure threshold. We know that patients who have seizure disorder, we may want to go somewhere else. We know that patients who have suffered from bulimia nervosa, self-induced emesis after eating, we may want to go to a different medication. So we ask this patient, do you have any seizure disorder? No. Have you ever suffered from bulimia? No. Do you have migraine headaches? No. And we document all of that. So the appropriate choice, the Wellbutrin. So we initiate Wellbutrin. Lo and behold, the individual is driving down the street, has a seizure while driving, runs his or her car into a light pole, and now we hear from a plaintiff's attorney who was saying that we should not have provided as our treatment approach the Wellbutrin. Is that an error? Perhaps. Perhaps it's an error in judgment. Perhaps. However, this is much more easily defended as an error in judgment because it is much easier for us to get a long line of colleagues who will come into the courtroom and testify that under the same circumstances and with the same training, they would have made the exact same interventional judgment. So again, key is to determine, is it an error in fact or an error in judgment? If I do commit an error, do I apologize? The traditional wisdom is never admit an error. However, modern perspective is to apologize with finesse. What does that mean? Let's look. Most medical errors actually go undetected. And most of those that are caught don't result in any harm to the patient. And earlier today, this morning, you heard a lecture on medical malpractice, and you realize that the key to medical malpractice are the 4 Ds. Duty. Do you owe the patient a duty? And if you do, is there a dereliction of that duty called a breach? Was the dereliction of that duty the direct cause of the damages? Most medical errors, there are no damages. When harm is caused, the question arises, how do we respond? Is there a role for an apology? And again, as you see, I put this in agonizing detail here on the slide for you, so you have a slide set of this, that under the old theory, the answer was you didn't want to apologize because that could be admitted into evidence against you as the physician in admitting an error. And it is because of that that there have been changes. Now, the Joint Commission requires hospitals to disclose to patients if an error has been committed. And that puts us as the physicians in a tight spot. Because if the hospital identifies that an error was committed and we are the physician of record for the treatment of the patient, if we don't make some kind of an apology, we look callous. So what's happened? Apology laws have been passed in 36 of the 50 states. And the apology laws fall into 2 separate categories. Category 1, Colorado, you can apologize and admit fault, and neither are admitted or admissible into the court to be used against you in a malpractice action. The majority of the states fall into Category 2, where you can make an apology. However, you cannot make a statement of fault because the statement of fault is admissible in a court of law. Now, if we look at the Missouri statute, and I'm going to show us the Indiana statute next. I'm showing you the Missouri statute first so you can get a feel of the difference between the statutes. In the Missouri statutes, it says, and I quote, "The portion of statements, writings, or benevolent gestures expressing sympathy or a general sense of benevolence relating to the pain, suffering, or death of a person and made either to that person or to the family of that person shall be inadmissible as evidence of an admission of liability in a civil action. However, nothing in this section shall prohibit admission of a statement of fault." Note in this statute that you can express sympathy for the pain and the suffering that the individual experienced. However, you cannot state fault or it's admissible. And note, you can express this to the patient, him or herself, and or to their family. However, if you make statements to other individuals, they can be subpoenaed to testify as to the statements you make. So this is very limited. Let's look at the Indiana statute. See, the Indiana apology law is a little different. You'll notice that here is the statute. Except as provided, a court may not admit into evidence a communication of sympathy that relates to causing or contributing to, and these are a loss, an injury, pain, suffering, death, or damage to property. Now again, how do we do this, and how do we handle this? There have been a lot of interpretations of these state laws, and most of the interpretations state that you can express sympathy. You have to be careful how you make an apology, because an apology itself can be construed as an admission of guilt. And that's the reason I put, we make an apology with finesse. So we can say to the patient, I realize that you were experiencing nausea and vomiting, and I know that can be very uncomfortable, and so we're going to change the medication so that you won't have to experience that. You and I discussed this before we initiated the medication, and you expressed understanding and gave informed consent. And we certainly don't want you to have to experience any of those side effects from this point forward. And so that's your way of recognizing, expressing sympathy, and moving forward. And so again, we have to be careful and cautious. I'm not trying to frighten you. I'm just giving you the legal issue here. If I employ a physician's assistant, a nurse practitioner, or a nurse in my practice, am I responsible for errors that may be made by this associate in my practice? And the answer is absolutely yes. Yes. And this is based on the concept of vicarious liability. Vicarious liability has three components to it, and I'm going to put that slide up momentarily. It's number one, that we are held liable for. Numbers 2 and 3 are now considered historical and archaic, and it all falls on number 1. I put them in for historical purposes. And what are those? The captain of the ship is no longer applied, nor is the borrowed servant theory. Under those theories, when we would go into the male or female surgeon would go into the operating room in the hospital, it used to be where we borrowed nursing staff and others from the hospital. And so we were considered as borrowing servants to serve in the operating room. That's archaic and that's historical. Captain of the ship, we were considered to be the captain of the ship in the OR. Now instead, it's respondeat superior. Let the superior reply. So what happens? This is the example I always give to students when I teach the course at the medical school, and I explain to them, if you have someone else in your practice, bless you, giving the injections, we all know that when you give a gluteal injection, we were all trained, you take, if it's on the right side, you take your left hand, you set it there, and you give the injection in the upper outer quadrant. You place the needle, you draw back to be sure you're not in a vein, because this is a intramuscular, not an intravenous injection. You draw back to be sure there's no blood, and then you go ahead and you give the injection. What is the whole purpose of this? To miss the sciatic nerve. So patient comes in, you make it a determination, the individual needs an injection. In my practice, we utilize injectable antipsychotics, long-acting antipsychotics for patients. We give some in the deltoid, we give some gluteally. It depends on what the medication is and the patient's preference. And my nurses give the injection. Even though in training I was the one who gave the injections, now because of time constraints, my nurses do so. And if a nurse in my practice gives an injection and hits the sciatic nerve? Does the liability impute to you? Yes. In today's world, the nurse may also be liable. However, the plaintiff's attorney is going for the deepest pocket. And so they're going for the gold. And so I just want you to know that respondeat superior, yes, we may be held liable. Again, it depends on state statute as well, so please check the state. It's the same thing. In the state of Missouri, where I practice, because of the size of our clinic, I do supervise several nurse practitioners as well. And the liability, yes, they have liability in malpractice insurance. I'm the supervising physician. So again, the deepest pocket, it will inure and impute to me. Prescribing. We're going to look now a moment at benzodiazepines, and then we'll look at antipsychotic medications, because these are questions I'm asked about on a regular basis. Benzodiazepines, excellent for anxiety, great for facilitating sleep, even for muscle relaxation. When we think about using benzodiazepines, are we responsible for the results of those? Well, of course we are. Any medication which we prescribe, we have responsibility for. When we think about benzodiazepines, what are we thinking about? We worry about tolerance. What is tolerance? Tolerance means the dose that has been prescribed is now no longer effective, and the individual either needs to increase the dose or increase the amount of times that he or she is taking that medication. What about dependence? Dependence means that if the individual stops taking that medication, that he or she will experience some kind of side effect from that, physical response from that, or withdrawal. Discontinuation can lead to withdrawal. So tolerance, dependence, and discontinuation, or tolerance, dependence, and withdrawal can lead to addiction. And so we have to be cautious today. Do I, as a psychiatrist, still prescribe a lot of benzodiazepines? I do, because for so many of my patients, they've already been to the promised land. Nothing else will do. So when they come in, I have to, in order to calm their severe panic disorder, their anxiety disorder. And I do it judiciously, and I explain to the patient up front that these are the potential risks and side effects with which we're dealing. And should I see them finding themselves in a situation where they are experiencing tremendous tolerance and dependence, we're going to have to look at a judicious downward taper and a modification to other medications. So again, I obtain informed consent, explaining to them these potential risks, and then I explain the future potential for the need of a downward taper to discontinuation. Now, when we think about the benzodiazepines, and I put this slide in as well, so that you have it in your slide set. So for those of you who are blessed and don't have to worry about using benzodiazepines, at least you'll have some history about the medication. However, for those of you who are in family practice, those of you who are in OBGYN, those of you who are in internal medicine, those of you who are in pain medicine and treatment, you're familiar with the benzodiazepines, and you're familiar with patients presenting to you and requesting them, and or patients who present to you already utilizing them. What do we do? How do we taper benzodiazepines if an individual is having difficulty with that medication? There are several different approaches. The typical and traditional approach is that we set up a judicious, timely, downward taper of the medication by small amounts over a week to 2 weeks at a time per downward stair step. And there's another option as well. The other option, because just as with treatment for diabetes, there are short-acting and long-acting forms of insulin-type medication, so too with the benzodiazepines. They're short-acting and long-acting benzodiazepines based upon their half-lives. And so when we think about that, we look at these half-lives. Alprazolam, Xanax, has one of the shortest half-lives. That's why it has a rapid onset of benefit. The dilemma is it has a rapid offset as well. Ativan has a little longer half-life, is also a little cleaner because it doesn't have the metabolites we see with some of these other benzodiazepines. Clonazepam has one of the longest half-lives, 20 to 50 hours. And then, of course, Valium is 30 to 60 hours. The major metabolite can last up to 100 hours. So what's one of the other options? And this is something that I do in my practice, unfortunately, on a fairly regular basis. I find patients will present to me who are on alprazolam, and they find that they've had to increase the amount of times they're taking it during the day. And now I already know they have tolerance, and I know they have dependence. And I tell them, we're going to have to intervene. We have to do something to help you through this. We may be able to switch you to a longer-acting medication that will cover your needs for your panic disorder and anxiety disorder. We may find that we're also going to have to taper you from that and move you to some other treatment approach for your anxiety. So I find myself moving from alprazolam to clonazepam. And what I find I can do with clonazepam, where the individual may be using a milligram of alprazolam, Xanax, 4, 5, 6, 7, 8 times a day, I can switch them to clonazepam and do maybe a milligram in the morning and a milligram about 4 in the afternoon, and I have them covered. Now, when they come into me and they say to me, Dave, I now am taking that one 4 times a day. Houston, we have a problem. And now I know I really have to get them on a downward taper, very, very gently and judiciously. And sometimes then I find I may have to move from the clonazepam to the diazepam, the Valium, and then, because then I can use less and slowly taper them down. I get another benefit from the diazepam. I get good muscle relaxation as well. So now they feel a full body calming, and then I slowly taper them off of that medication. And in a little bit, I'll open it up for questions if you have questions on this, because I certainly don't want to put you all to sleep or give you indigestion while you're eating your lunch. What about atypical antipsychotics in the elderly? This has become a hot topic as well. And I gave you a lot of information on the slides about atypical antipsychotics, their mechanisms of action. I wanted you to have that information. I don't know how many here in the room utilize the atypicals. However, many of you will have patients who present to your practices who are on atypicals. And when someone is young and vibrant and robust, we don't have to worry as much as when they cross that threshold and you're becoming elderly. I now meet the criteria for being elderly. Wow. It does help me get into movies a little less expensively. When we think about the antipsychotics, whether they are the typical, the older line, the ones we think of when we think of haloperidol, prolixin or flufenazine, Navaine, thiothixine. When we think about the old line, we think about the individuals who had a lot of motor function disturbance because of blocking dopamine in the nigrostriatal pathway, and we saw the tremor, and we saw the stiffness of the muscles. So we moved to the atypical antipsychotics. The atypical antipsychotics were thought to have less potential for extrapyramidal side effects, thought to be safer in use. However, what we found in 2005, the studies came out and said, well, that's well and good, however, not in the elderly, with dementia. It's the patients with dementia that they said you have to be very careful because the atypical antipsychotics can lead to cerebrovascular accidents, to strokes and death. In the elder care patient who is in the nursing care facility, who is demonstrating agitation, irritability, and even violence, we were using the atypical antipsychotics, and they came out in 2005 and said, oh boy, this may be a real issue. These may present danger of stroke and death. So many practitioners then went back to the typical antipsychotics, and then in 2008 the study came out and said, you know, we think the typical antipsychotics may be just as bad. So now our hands are tied. So let's look at this. And I gave you all this information. I hope that's okay, so you have it for your later study. I didn't want to bore you with it over lunch. What are the key things we worry about with the atypical antipsychotics? We worry about metabolic syndrome with the atypicals. What does that mean? Triglycerides, cholesterol, insulin. We worry about disrupting those in our patients. They become obese at the equator. They start to have increased triglycerides. We can see cholesterol increase. We see blood sugars go up so that the individuals now are showing signs and symptoms of diabetes. And we have to intervene and treat. So now we are kind of at a crossroads. How do we intervene and treat for our elder care patients, especially those with dementia, who are demonstrating irritability, anger, and violent outbursts? Well, when we look at these, I gave you all a slide with the different medications, the different disease states, including dementia, and what the appropriate recommended doses are. And you'll notice that the one medication in dementia that is considered still to be the safest, notice, not totally safe, it's just considered, of all of the agents, the safest is the quetiapine. And please know, I'm not here funded by the company that manufactures that. This is coming out of some studies that I read. I have copies of them with me. And so when you notice here, I really did hit the wrong button at this stage. If I hit it back, will it bring it back? If I hit the same button or no?
No, it hits.
Yes, if I hit the, or do I do it on the computer? Let's, I'll just hit this. Now I'll go back to slideshow. And I appreciate it. Just right here. Thank you both. Thank you. Please, a round of applause for our colleagues. Thank you. Thank you very, very much. So when we look at these, I was going to hit the, but now I'm not going to. I won't use the pointer because God only knows what I'll do next. So when we look at these, it gives us an idea, and that's why I wanted it in your slide set. If you need to look to see what do I do, this gives you some of the doses, especially for our elder care patients who suffer from dementia. You'll notice the quetiapine at 50 to 100 milligrams. Is that a lot? FDA-approved package insert dosing for quetiapine in the standard patient with psychosis, we can dose up to 800 milligrams in a day. You'll notice here we're looking at 50 to 100 is the maximum dosing. And again, how do we typically use it? For the individual who is demonstrating the behavioral acting out, we may use as small an amount as 25 milligrams once, twice, or even 3 times a day. If we do that, then we're still staying below that 100 milligram dosing. So we have to be very careful. What used to be used regularly was the risperidone, and that was used regularly. And again, we have to be very careful with that now. The recommendations are to avoid that if you can. And in fact, if there are other treatment approaches, we prefer other treatment approaches first before we utilize the antipsychotics of any type, whether it be the typical or the atypical. And I have studies I can show you that state the behavioral interventions and the social interventions, alas, for many of our elder care patients with psychosis and dementia, they're just not as effective. We need to intervene with medication. We've made it through the slide set, and that brings me to the point where I will entertain questions. If you have any, and please, you can ask me about anything. With regard to either legal issues, you can ask me about psychiatric issues, you can ask me about medications. Yes, please.
I had a patient in the emergency room who listed no allergies,
We gave her a dose of Vectrum for UTI, and then she said, well, I'm allergic to Vectrum.
Yes.
So we gave her 50 milligrams of Benadryl,
Yes.
and we waited 30 minutes, and nothing happened, and we sent her home. And then 2 weeks later, I got a letter from the medical review committee saying that I should have watched her for 4 hours in the emergency room because I didn't wait long enough to see if there would be an allergic reaction. That didn't make sense to me since the patient had no symptoms of a reaction, and also I thought 30 minutes was adequate time to see if something's going to happen. Obviously, there's people on administrative floors who review everything after the fact and felt that you should send me a letter.
Yes. Monday morning quarterbacking is always 20/20 hindsight. It's always perfect. And you're right, because we know as clinicians, side effects typically, especially that type of a side effect, is going to come on board pretty rapidly. We know that. However, this is one of the dilemmas in our practice of medicine. We are at the whim of the boards that evaluate and review. So again, if we can, it's important to even ask in advance now. Everyone here in the room is on notice. If you're working in an ER or if you're working in a clinic, ask them if they have guidelines on what they want us to do. And that way, we at least have advance notice. The reality is as well, the key in this situation is to document patient inquiry was made with regard to any allergies to medications. Patient denied any allergies to medications, and that's now documented. And this happens. And what you're saying, it's the same kind of thing. If you had any surgeries and the patient goes no, and hour later in the interview, you say something to the patient, they say, yeah, you know, when I had my appendix out, it's like, wow, how did they do that? Through psychic surgery? You know, but this is what happens, and this is a dilemma. And I'm sorry you had to go through that.
But they keep those letters in their file.
They do. They stay. Yes. Yeah. Yeah. Please, other questions if you have. Yes, question.
Just a comment. One of the things, I'm in palliative medicine, and one of the mistakes that I see is that when people treat geriatric delirium, they often use a benzodiazepine, which makes things considerably worse. And the drugs of choice are, well, the old tried and true is Haldol, haloperidol, or one of the newer antipsychotic agents. And so in that type of situation, we often talk to the family members about the possibility of cardiovascular events and these kinds of things when we prescribe the medication. But we use such low doses, and I don't know if these are really dose-dependent, these particular events. But knock on wood, I haven't really seen anybody have an untoward side effect. We use it for a short period of time.
Yes, yes, and I appreciate that. When talking about delirium and intervening to treat, it is important. And still, I think utilizing, the comment is made not to use a benzodiazepine. A benzodiazepine will only cause more confusion and certainly doesn't help to clear what used to be called the hospital psychosis. And the delirium, the difficulty with delirium is there's some other underlying disease state leading to the delirium. We don't understand the mechanism of action of delirium. And the delirium that's so frightening is 33% of patients who develop a delirium within the first 3 months are at risk of dying from some unknown cause, and 50% at the end of a year. And we don't know the mechanism. We don't understand it. However, it is important to clear the delirium as quickly as we can, and I appreciate that. And we do use very low doses, and I still think Haldol in very small amounts is still one of the best treatment interventions for that. Yes?
Also, what we're finding now, a person by the name of Inawi, who I'm not sure if I'm pronouncing the name, she's done a lot of work with delirium, and one of the things that she's finding is that there's a persistent effect cognitively in some of these individuals in the elderly that develop this syndrome. And so, and it may not entirely clear in situations where we can't find something that's reversible.
Indeed, and I appreciate that because delirium, in so many ways, like other psychiatric illnesses, such as schizophrenia and bipolar disease, when individuals experience a new episode, it is neurotoxic, and it destroys neurons and pathways, and the individual then may not come back to their pre-morbid baseline. And this is one of the dilemmas we face in psychiatry. As I was talking with a colleague earlier, when we were talking about individuals utilize their medications, especially in psychiatry, similar to an antibiotic. After 72 hours, they feel better on the antibiotic, they stop the antibiotic. Same thing in psychiatry. Individuals, once the acute episode of depression, the acute episode of psychosis, the acute manic episode clears, the individual stops the medication. And then alas, because they feel better, then they have a recurrent episode, and now it's neurotoxic, and we see damage to the neurons, and they don't come back to their original baseline. And we know with delirium, it's very similar. And we want to avoid anticholinergic meds because those exacerbate delirium, so we have to be so cautious. Yes. Please, any other questions? There's a reason I'm asking, because if not, I may do several visual demonstrations. Yes, yes. Question? No.
Long before they did Seroquel or whatever, I had an ALS, end-stage ALS patient.
Yes.
I forgot why we hospitalized him. But he wanted to die. He knew he was at the end of his rope. His wife, though, wanted to do everything to keep him going. And I'm like, but his main problem was severe anxiety and insomnia. He just could not, and I'm like, I gotta treat this guy. You know, I don't want him to, the last days to be miserable. So I tried to explain it as, you know, I forgot what I used. I probably had used a benzodiazepine. And, you know, I was lucky I was able to talk the wife out of suing me because he passed in about a week. And I had to be honest, I said, yeah, well, you know, if his muscles got weaker, maybe he didn't breathe as well, but that's the way he was going to die anyway. But what drugs would you use in a case like that? How would you approach a patient like that who doesn't care if he dies, wants to die, he's never going to get better, and you want to let him get some peace and relax and sleep?
And this end-of-life care, this is where, in palliative care, this is what we look at. And I think one of the keys, for so long as the individual with ALS, they're still mentally intact, you know, they're usually still very sharp. It's the body that's failing, not the mind. And so it's important, for so long as they have not been adjudicated incompetent, so long as they're still competent, and they don't have someone else who's serving as their durable power of attorney at that moment, it's important to talk with them and to get that individual's informed consent for treatment approach and bring the rest of the family in and say, this is what Mr. Jones wants. You all are the family. You guys talk together. However, this is what your husband's saying or what Dad is saying. Okay, now we've established that. So then we have to explain to them, we have a limited time frame here. And so we want your husband to have the most comfortable transition possible. So we want to get him sleep. We want to calm the anxiety. How do we do that with the least amount of adverse side effect? Because we don't want to make things worse. And we look at the medications. Is a little judicious amount of a medication such as a Seroquel, can that help? And the answer is it can, because it calms anxiety. It can also facilitate sleep. Now, the benzodiazepines, they're great for affecting both. However, can they exacerbate the respiratory depression? And they can make that worse. I don't know if I'm giving you a pleasing answer or not. The ultimate key is getting the family together and talking with them first and explaining to them what's really at play, because no matter how we intervene, especially for this individual, eventually they're going to pass, and we don't want that passing to be uncomfortable to the point for the family that they blame us for the passing, when in fact, it wasn't us. We were doing our best to calm the passing for them. Does that answer?
Yeah.
And please, yes.
Well, one of the things that we do in situations, it's a question of how and what kind of distress that individual is. And in situations where people are really uncontrolled, and we see uncontrolled suffering, and we're trying all different things, there is use for what we call palliative sedation. And we explain that. Sometimes we get a psychiatric consult to kind of help us in this regard, maybe an ethics consult. In a situation who has a person who has severe distress and simply just doesn't want to live that way. And our intent is not to bring apart, not to cause the person's death, but to bring the person's, or to control that person's suffering. And so that's what makes a difference. There's a principle of double effect, for example, in ethics, where you have maybe a possibility of what you're prescribing, like on the battlefield, if someone is injured and you know they're moribund and they're in a lot of pain, and you give them a shot of morphine, and maybe that injection might hasten their death. But that's not the intent. The intent is really to control the suffering. And, you know, when we're taking care of a person like that, it's how intense is this suffering, and how much is it affecting that person's end-of-life care? And what else do we have to treat that person?
Thank you. I appreciate it. And this gets back to the bioethics of the, autonomy. The individual has the right to say what he or she wants. The beneficence do good. Non-maleficence do no harm. And the justice is the concept of the allocation of resources and what we can do. And again, that's the reason. We sit down with the family. We talk to the ethics committee. If you have an ethicist at the hospital, you want to bring them in and have the ethicist meet with the family as well and discuss these issues. Because as the physician, we're there to heal and to calm suffering. And we have to explain to the family that there's a whole ethical pathway in this process. And that's where hospice comes in, and palliative care. And so I appreciate that. I'm going to ask, if I might, to help visualize all of this, I brought a deck of cards with me, not as a means of showing a misspent youth. But I brought a deck of cards. Which I will shuffle so that hopefully these cards are as mixed up as I am. And I'm going to ask, you please just to say stop at any time to it. And then I will take these rubber bands and rubber band the deck shut. And now in a moment, I'm going to pass the deck to several tables. And when I hand you the deck, I'm going to ask you please just to take the deck, to crack it open, look at a card, drop it back down. Please remember your card, and then I'll ask you to stand up. And then I'll get the deck back and I'll hand it to someone else and say, please crack the deck open, look at a card, remember it, and then stand up. So I will come first. May I hand you this deck? And I'm going to ask you please to take it, crack it open, look at a card, remember that card, drop it down, and I'll have you stand up. Thank you. And I appreciate all of those of you who are willing to participate. I thank you. May I hand you the deck? May I ask you, please, Dr. Allen, have you crack it open, look at a card, please remember that card. I'll take the deck back, and then I'll have you stand up. Very good. Thank you. Now come across. I don't want any side of the room to feel left out. May I hand you the deck? I'll have you crack it open, look at a card, remember it, and then I'll have you stand up and I'll take the deck back from you. Very good. Thank you. And may I hand you the deck? Thank you. And have you crack it open, look at a card. I'm going to ask you please to remember that card as you stand up, and I will take the deck back. Very good. Thank you. And we will do one more. May I hand you the deck? I'm going to ask you please crack it open, look at a card, remember, stand up, and I'll take the deck back. Thank you. Now, a deck of cards, shuffled. Just as patients present to our practices as if from a shuffled deck randomly dealt into our schedules every day. We see them. First thing we want to do is establish rapport. And then we want to do our best to understand what's bringing them in to see us, making an accurate diagnosis, obtaining informed consent before we intervene and treat. Now I'm going to ask each of you, if you will, because I don't want to be reading body language or facial signs. I'm going to ask you all please to turn your backs on me, if you will. I won't consider that as a sign of rudeness. I'm going to have you all turn your backs, and in a moment, I don't want you to do anything yet. I am going to call out 2, 3, 4, 5. Please picture the card in your mind's eye, because I'm getting the impression of a 3 of clubs, a 5 of diamonds, an 8 of spades, a queen of hearts, and a jack of clubs. If I mentioned your card, please turn around and take your seat. Thank you. Please hold your applause. Thank you. We have one more card that was selected at random from the shuffled deck that none of us have seen. Am I right? Dr. Booth has it right here on the table. 52 cards plus the 2 jokers are in that deck, because you'll notice I left the jokers in the deck. One card was selected out of the 54. None of us have seen it. None of us know what it is. However, this card helps us to realize that when we talk about medical legal issues, we also want to be aware of the need for insurance, malpractice insurance. You see, even as a magician, I have to carry insurance. I have the magician's insurance policy. And what you will notice, the policy says it has conditions. What is the most common contract entered into in the United States? The insurance contract. What is the least often read document in the United States? It's the insurance contract. So my insurance policy has to provide me everything I need. And I'm going to ask now, if you will you please, Dr. Booth, will you please pick up the card, show us what it is, and announce out loud the actual card. It is the
King of Hearts.
The King of Hearts, and hopefully our insurance policy covers everything we need. Thank you all very, very much. It was a real honor and pleasure to be here today with you all. Thank you. Thank you.